I hope it will work. Full screen. Okay. Thank you very much. And good afternoon, everybody. Yes, we will discuss about protective ventilation in the OR. You know that it's one of my own topic, but I'm quite sure that you are also very interested in these concepts of protecting the lung during mechanical ventilation, especially during general anesthesia. So I have to declare some disclosure, of course, and some consulting activities, especially with Drager, so keep in mind that I have some disclosure, of course. So the agenda, and please, we are going to start the lecture with some data on postoperative pulmonary complication, because you know that postoperative pulmonary complication today are a very important problem, and I'm quite sure that in your daily practice you are always faced with patients who develop postoperative pulmonary complication. Unfortunately, there are very important data coming from the ESA study. I'm quite sure that you have heard about these very interesting multi-center European studies, which was performed in 2011, supported by ESA and ESIGM. And in this study, which included more than 40,000 patients during 1 week, we found that mortality after surgery is quite higher than anticipated, or at least higher than expected, because in Europe today, postoperative mortality is around 4%. As you can see, the overall in-hospital mortality after elective and non-elective surgery is around 4%. So I hope that you have this information in mind, because 4% mortality following surgery is probably too high. And if you ask your patient, will you able to take the risk to be operated if you have 4% of risk of dying following surgery, I'm not quite sure that your patient will say, okay, let's go for surgery without any problem. Okay, so 4% mortality, it's quite high. We have obviously some difference within countries, with the reference which was for the UK. And postoperative pulmonary complications are one of the most reasons for dying after surgery. And in this very interesting study published in 2014, which included individual data from patients included in 12 observational and randomized controlled trials, the authors found that the overall incidence of postoperative lung injury was around 4%, but we are discussing about postoperative lung injury, a very specific type of complication. And in patients who developed postoperative lung injury, as you can see on the right of the slide, postoperative mortality was close to 20% as compared with 1.4% in patients who did not develop postoperative lung injury. The other very important information from this study is that postoperative lung injury did not appear during the stay in the postoperative care unit, but several days after. The peak was around day 3 following surgery, so the patient will develop complication not during the immediate period following extubation in the postoperative care unit, but within the days following surgery, with the peak within the first week after surgery. Other important information is the price to pay for this kind of complication. Of course, the price is not the same for a patient who will develop a pneumonia or will just requiring oxygen therapy. And in this very interesting multi-center study coming from the 7th center in the US, including more than 1,000 patients operated from abdominal, orthopedic, and neurological procedures, so very common procedure, they found that there is an overall incidence of postoperative pulmonary complication of more than 30%. 30% of patients developed postoperative postoperative pulmonary complication, and they evaluated the incidence of different kind of complication using either clinical and radiological criteria. And as you can see, for example, the price to pay for pneumonia following surgery is a relative risk of death of 15%. 15% risk of death because of pneumonia following surgery. And as you can see, the need for postoperative non-invasive ventilation or the need for reintubation following surgery is associated with significant risk of death, 7% for non-invasive ventilation and 28% for being reintubated because of respiratory failure following surgery. So the conclusion of that is that we should make every effort to reduce the incidence of postoperative pulmonary complication because the price to pay for our patient is very high in terms of mortality. Okay, the patient will die from the complication following the next day following surgery. And unfortunately, during surgery, at least during general anesthesia, patient will require mechanical ventilation, of course, because of general anesthesia by itself. You will have to ventilate your patient during several hours. Of course, it depends on the duration of surgery. But we know now that even for a very short period in time, you can create some damage within the lung if you don't use appropriate setting for the ventilator. And the damage that can appear are resumed within the terms of ventilator-induced lung injury. And as you know probably, that ventilator-induced lung injury comes from different mechanisms. The most famous one are atelectrauma, overhead distension, and of course barotrauma. But at least atelectrauma and overhead distension, they are responsible for structural consequences within the lung, biological alteration, and in some patients also some systemic effects which are responsible for organ dysfunction and some deaths also in some patients. So the trigger is inappropriate ventilator settings, and with inappropriate ventilator settings you can create the conditions of possible organ dysfunction within organs distant to the lungs. So please be careful with your immediate settings because you can create some adverse events, especially during surgery, because during surgery you know that patient will be mechanically ventilated, of course, but they also will receive some fluids. They also will receive, in some cases, blood because of blood losses. So transfusion, fluid, major surgery, ischemia, reperfusion, and so on are responsible for aggressions for the patients, which can accumulate with the mechanical ventilation to create a multiple hits to the patients, and these multiple hits can create the condition, of course, of biotrauma and all dysfunction to a distant organ distant to the lungs. So should we apply protective ventilation in all patients? At least for abdominal surgery, it's not the case for other kind of surgery today, but at least for abdominal surgery, we have data coming from two studies, the IMPROVE, and we will discuss about this study just after. The IMPROVE study, and the other one is the PROVHILO study. Both of these studies were published, as you can see, in 2013 and 2014. So at least for abdominal surgery, we have data to discuss about the usefulness of protective ventilation during surgery. The IMPROVE trial, as you probably remember, compared in fact two strategies. The first one is a non-protective ventilation approach that used a tidal volume of 10 to 12, no PEEP and no recruitment maneuver, which was at least a routine approach at the time the trial was created. And this non-protective ventilation approach was compared to a lung protective ventilation approach using lower tidal volume, 6 to 8 milliliter per kilogram predicted body weight, a moderate PEEP level, 6 to 8, not too high, not too low, and recruitment maneuvers during surgery. In both groups, patients were ventilated using volume control and targeted plateau pressure of no more than 30 centimeters of water. The FI2 was adjusted to maintain pulse oximetry at least 95%. And again, a respiratory rate adjusted to maintain end-tidal CO2 within quite normal ranges. The primary outcome of the IMPROVE trial was a composite outcome of pulmonary and non-pulmonary complication following surgery by day 7 after surgery, and we found that in the lung protective ventilation, with the lung protective ventilation approach, there was a significant reduction in the occurrence of the primary outcome. and also a significant reduction in secondary outcomes, including the use of invasive or non-invasive ventilation following surgery because of respiratory failure. So the conclusion is, or was, as compared with a non-protective ventilation approach, clearly the use of a protective ventilation using lower tidal volume, moderate PEEP, and recruitment maneuver was associated with significant benefit in terms of pulmonary complication and so on. The question is, should we use higher versus lower PEEP in these patients? Because in fact, in the improved trial, as you can see, we have compared and we have used a bundle of care, a multifaceted approach that use lower tidal volume PEEP and recruitment. And the question is, should we use finally lower or higher PEEP in the OR? And that's the question of the PROVHILO trial. In the PROVHILO trial, they compared two groups of patients. In each group, a lower tidal volume of 8 milliliter per kilogram was used, but they compared two levels of PEEP, a lower PEEP level, a PEEP less than 2 centimeters of water, to a higher PEEP group in which PEEP was set at 12 centimeters of water, so a quite high level of PEEP in these surgical patients. Again, the primary outcome was the composite of postoperative pulmonary complication, and they found absolutely no difference, as you can see, 30% as compared with 39% in the lower PEEP group of patients developed postoperative pulmonary complication. But unfortunately, or as expected, I don't know, they also found that the use of 12 centimeters of water and recruitment maneuver was associated with hypertension and more need for vasopressive agent administration. So their conclusion was that a strategy of higher level of PEEP and recruitment does not protect against pulmonary complication. And the second part of the conclusion was that an intraoperative protective ventilation strategy should include a low tidal volume, and we will discuss about that, and a low PEEP without recruitment maneuvers. But as you probably know, or you will know that, I totally disagree with this conclusion. This conclusion is, from my point of view, very dangerous, because first of all, and they were not able to find a significant difference between these two groups. So it's very difficult to promote the use of a very low PEEP level without recruitment maneuvers, because in fact at the end there was absolutely no difference between these two groups of patients. The only things they found that the use of a PEEP of 12 and recruitment maneuvers was associated with a more important frequency of hypertension and use of vasopressor, but it's not a positive outcome. Okay, and in fact, we know for several years ago that if you applied very high level of PEEP and of course recruitment maneuvers, you will create the condition to observe a drop in cardiac output and arterial pressure. You don't have to include 900 patients in a randomized controlled trial to find that if you applied 40 or 50 centimeters of water of pressure within the thorax of your patient, you will observe a decrease in arterial pressure and cardiac output. For example, this very interesting paper, experimental study, found that whatever the model you use, VLE or pneumonia, when you applied a recruitment maneuver, you observe a drop in the cardiac output and also a drop in arterial pressure during the recruitment maneuvers. So if you decide to apply recruitment maneuver, you should keep in mind that you will have a drop in arterial pressure and you will observe also a drop in cardiac output. That's a conclusion and a necessary conclusion of the strategy if you decide to apply such amount of pressure. And the other conclusion of the paper is that the highest drop in cardiac output and arterial pressure was observed in patients that received the highest level of pressure following recruitment. So if you applied a recruitment and at least 12 or 10 centimeters of water following recruitment in patient who does not need to have such high level of pressure, you will have some hemodynamic negative effects. Okay? So again, these kind of side effects are very, very known. The second information is that obviously there is a problem with tidal volume. If you applied a high tidal volume, at least a tidal volume higher than 8 or 9 or 10, you will observe an increase in postoperative pulmonary complication. But again, be careful, because if you reduce the tidal volume too high, below 6 or below 5 milliliter per kilogram, you can be also in a situation in which the patient cannot be protected from lung recruitment. And lung recruitment is also a very known problem with the reduction in tidal volume. And if you decrease the tidal volume with a moderate level of PEEP without performing recruitment maneuver, you will observe this kind of results that are referred to lung recruitment. In this study, I don't know if you have heard about this very interesting study from the group of Laurent Brochard. They compared two levels of tidal volume, 6 versus 10. The PEEP settings was exactly the same in the two groups. They set PEEP just above the lower inflection point on the PV curve, and they compared the lung volume in these two groups. As you can see, before applying a recruitment maneuver, when you decrease the tidal volume, the blue bars, you can see that there is a significant lung recruitment. And if you want to prevent from the recruitment, you have to apply a lung recruitment maneuver. So the key message of the trial is that if you decrease the tidal volume and if you decide to apply a very low or moderate level of PEEP without performing a recruitment maneuver, there is a huge risk of observing lung recruitment. And if you have lung recruitment, you also create the condition for postoperative pulmonary complications. So please be careful. If you decide to apply the lung protective mechanical ventilation approach, you need to have a lower tidal volume, PEEP, of course, PEEP. We can discuss about what is the optimal level of PEEP, but you need to have PEEP, and you also need to apply recruitment maneuvers, because if you don't apply recruitment maneuvers, you are faced with a risk of lung recruitment. And when you look back at the first trial I presented in the introduction, again, this multi-center trial, multi-center prospective study coming from the US. Finally, when you look at the tidal volume in every patient, there was a lower tidal volume ventilation approach applied in this patient. So tidal volume alone is not the key for the difference between patients who will develop postoperative complication or not develop postoperative pulmonary complication. So, of course, we need to decrease the tidal volume, but it's not the only things to do. You need to apply something else than only decreasing the tidal volume. Again, very interesting information coming from the US. More than 20,000 patients included in these studies. In fact, it was retrospective studies. And the question asked by the authors was that, finally, in the recent years, we modified our strategies of mechanical ventilation, and they want to know, finally, if clinicians applied the reduction in tidal volume between 2008 and 2011, and they found that the use of a lower tidal volume ventilation approach increased in the utilization, in daily utilization by clinicians. But at the same time, they were able to find an increase in mortality and morbidity in patients. As you can see, there is a clear risk of postoperative morbidity and mortality associated with the use of a lower tidal ventilation approach alone. Because in this trial, in these observational studies and in this observational data, they only found that the use of a lower tidal ventilation approach alone without sufficient PEEP and obviously without recruitment maneuver was associated with detrimental effects. So again, be careful. If you decide to apply only lower tidal volume, you will have some side effects and probably some morbidity and unfortunately some mortality also. But when you combine again all the data, all available data, there is a clear benefit of protective ventilation, and the protective ventilation benefits come from lowering tidal volume, but also using higher level of PEEP. And again, the conclusion of the PROVHILO trial, 2 centimeters of water for the PEEP level is probably very dangerous. It's, from my point of view, very dangerous to limit the PEEP to this such low level, and probably the right thing is to use a moderate level, no more than 10. Probably in every daily patient, you don't need to have to apply more than 10. Probably the good range is between 5 and 10 in most of our patients. Not too less, but probably not too high also. And finally, to conclude, I'm quite sure that the final approach will be to more individualize our settings. How can we do that? Probably we need to have a multi-parametric approach, again, a kind of bundle, to be more precise in the settings of PEEP in every patient. And you can easily do that by combining, for example, different parameters. And in this very interesting paper, they decided to evaluate the behavior of functional residual capacity, compliance, PO2, and dead space during a recruitment maneuver with 2 steps, as you can see, increasing one and decreasing phase of the recruitment procedure. And as you can see, they were able to identify the point of pressure for this individual patient that combine the highest PO2, the highest compliance, the lowest dead pace, and the highest functional residual capacity. It's very difficult at the bedside to individualize PEEP, but if you have this kind of approach to evaluate the behavior of your patient regarding modification of the compliance, for example, of the PO2 or other parameters are also possible to evaluate, you will be able to find the optimal PEEP level in every patient. And the second approach is to set our setting on driving pressure. You know probably this very interesting meta-analysis published in the New England Journal of Medicine 2 years ago now on the driving pressure. I'm not sure that everybody is very familiar with the driving pressure. The driving pressure, in fact, is the difference between the plateau pressure and the PEEP. And the concept is that probably it could be interesting to more individualize our settings to finally the size of the available lungs for gas exchange, and probably one of these approach could be to use the driving pressure. To give you an illustration of the propos, what are the modifications of the driving pressure in case of PEEP and plateau pressure modifications? For example, in the first case, you have PEEP of 10 in every kind of situation. The PEEP is 10 for everybody, but the plateau pressure is increased from 20 to 35, and as a consequence, of course, there is an increase in the driving pressure. That is, when you perform 20 minus 10, you have 10, and when you perform 35 minus 10, you have 25 driving pressure. So in these first cases, the PEEP is kept constant, but there is an increase in driving pressure because of an increase in plateau pressure. The second situation, at this time you have a constant plateau pressure, but an increase in PEEP. And when you increase PEEP, the consequence is a decrease in plateau pressure, in driving pressure, sorry. So when you perform the difference between plateau and PEEP, again, you found a decrease in driving pressure. So this second situation, constant plateau pressure and decrease in driving pressure because of an increase in PEEP. And the third one, finally, modification of PEEP and plateau pressure that maintain driving pressure constant. Okay, so everybody is okay with these 3 kinds of situations. And in this meta-analysis, they were able to find out mortality in RDS patients is quite different according to the modification of driving pressure. And in the first cases, of course, when the driving pressure increases, there is an increase in mortality. When driving pressure decreases, there is also a decrease in mortality. And obviously, when driving pressure is kept constant, there is absolutely no modification in mortality. And again, when they perform secondary analysis, they found that in all patients who received a lung protective ventilation using a low tidal volume and a plateau pressure below 30 centimeters of water, which are the rules for ventilation of RDS patients, the only things that differentiate patients who will survive or not was the driving pressure below 12 or 13 or higher than 12 or 13. There was no difference in plateau pressure within this group of patients and also no difference in tidal volume. And we have exactly the same things in the operating room. In the operating room, you can have exactly the same modification of driving pressure according to your settings of tidal volume and PEEP. For example, when you have an increase in the driving pressure because of an increase of the plateau pressure or the PEEP, you will observe an increase in the risk of postoperative pulmonary complication. And again, when you have a decrease in the driving pressure, for example, below 13 in these cases, whatever the plateau, whatever the tidal volume, for example, even when you have a tidal volume higher than 10, if the driving pressure is below 13, there are, in this analysis, no risk or no increased risk of postoperative pulmonary complication. The same is with PEEP. If you have a higher level of PEEP, more than 8, and this high PEEP is associated with an increase in the driving pressure, was associated with an increase in postoperative lung injury. And finally, maybe it could be a good option to more individualize our setting in daily practice. If you have the possibility to have a look to the plateau pressure, the PEEP, and you make the difference. If you have a setting that is associated with a low driving pressure, probably that this very low driving pressure will be associated with a decrease in the risk of postoperative pulmonary complication. So to conclude, and not to be late, I'm quite sure that now we have sufficient data to change our way of thinking, and probably we have to make more efforts to prevent the occurrence of postoperative pulmonary complication. This is very important because, again, postoperative pulmonary complications are responsible for a very high incidence of morbidity and obviously mortality. Even in patients who are ventilated for such low period in time, that is the case during general anesthesia. Even in this patient with healthy lung during general anesthesia, there is a risk for ventilator-induced lung injury. So even for very short cases, you have a risk of creating condition of pulmonary complication. So please be careful again. And whatever you are in the ICU or in the OR, lung protective ventilation should apply low tidal volume, probably a moderate level of PEEP. You have to more individualize your settings probably, but you have also to apply recruitment maneuver. And with my friend Samir Jaber, we performed 2 years or 3 years ago now some recommendation, but it's our own recommendation. It's not international consensus guidelines, but you can find these guidelines in anesthesiology. They are available. And probably the next step will also be to include this kind of multifaceted approach into a more general one, including the preoperative but also the postoperative phases of the case, including probably the use of NIV before and after surgery. So thank you, and I will be able for questions at the end of the second lecture. Thank you very much.